welcome to Cosylab's webinar, in which we would like to present our solution for implementing an adaptive therapy based on daily imaging. My name is Gregor Humar, and I'm responsible for the medical domain business in Cosylab. For those of you who don't know Cosylab, we are a group of over 200 experts specialized in the development of entire spectra of radiotherapy solutions. We are offering solutions from low-level control, like control of cyclotrons or synchrotrons, through safety systems and real-time control, like pencil beam scanning, to clinical systems like R&V and OS, called Oncology One. Today is with us Niek Schroeder, one of the pioneers of proton therapy. Niek is well respected and known in the PT community for his innovative solutions for standardizing and simplifying PT facilities to reduce the costs and time to market. Niek is also a board-certified medical physicist with significant experience in all aspects of proton therapy. He's currently serving as the president of proton therapy at Leo Cancer Care. Niek, welcome, and thanks for being with us. Also with us today is Sašo Pulko, who is the chief of medical physicist at oncology department at University Medical Center Maribor, where the presented workflow is being implemented. Hello, Sašo, and welcome to you as well. Now I will give the word to Kristjan Anderle, who is our product manager, and he will present how daily images, for example, CBCT or CT that are used for positioning, can also be used for adaptive workflows. Kristjan, the stage is yours.
Thanks, Gregor, and hello and welcome everyone to our webinar from my side as well. As we know, in the standard radiotherapy clinical routine, the treatment plan is created by a TPS based on the CT simulation, then QA'd using dosimetry equipment, and finally fractions are executed using this initial plan. All is basically based on this initial snapshot from the past and doesn't really change during the treatment. However, due to anatomy changes such as tumor shrinkage or weight loss or even some other factors, the initial plan could fail to meet the prescription. In theory, each patient could be replanned daily with proper imaging. However, we all know that in the current setup, the clinical personnel usually lack the time to analyze each patient's fraction. A lot of data is generated and acquired during the treatment, most notably the cone beam CT or in-room CT images, but they're not really used afterwards to facilitate the treatment process. And we want to change that. Let's exploit the data we already have and assess patient anatomy changes and evaluate its impact on the dose distribution automatically. Thus, we could tell which patient require plan adaptation and which don't. And all this is done automatically in the background without any extra time or effort from the clinician and does not interfere with the clinical process at all. This gives full power to the clinician to focus on the patients that require special attention. Niek, if you could say a few words about plan adaptation, we'd really appreciate it.
Yeah, I want to make sure that everybody understand that plan adaptation is a really important aspect of modern day radiation therapy, and more so in proton therapy. In the clinic, while I'm still involved at Provision Proton Therapy Center in Knoxville, we're adapting 17% of certain disease sites, and about 13% of all patients over the entire pool gets an adaptive plan. But if we adapt only 13%, then it means we need to do these adaptive evaluations over many, many more patients. So that's a very, very important parameter to investigate and to figure out, is there a better way to figure out whether a plan needs to be adapted or not.
Thanks, Niek. So as you could hear, the adaptation is really important in a clinical routine. And on the other hand, the clinical personnel doesn't have the real time to do this in an efficient manner. And we want to save them the extra time that would take to determine which patient needs adaptation by doing this automatically and by using the cone beam CT images that were already acquired for patient positioning. And with that in mind, we developed the Oncology One, an oncology system which streamlines adaptive radiotherapy workflows. What you see here is the Oncology One home screen, where we have a clear overview of patients scheduled for different machines. In this example, in our clinic, we have PT Room 1, Linac 1, and CT Simulator. On the right, there's a whiteboard with tasks listed that are assigned to our care team and sorted according to the respective due date. We only see contouring tasks for our case, because we're part of the contouring care team, but we could also see tasks for other care teams if we wish to do so. Now let's imagine that we come to our work in the morning, we get a cup of coffee, and after we checked our emails, we open the Oncology One welcome screen to check the schedule for the day and our tasks. Today, all patients have green flag, meaning that previous fractions were okay and they don't need any plan adaptation. Of course, this will rarely be the case, and we will demonstrate in this webinar what's behind these flags. Now let's demonstrate this by opening a patient called Mr. James Johnson that was scheduled for room PT1. What we see in this screen is an overview of patient treatment course for prostate tumor diagnosis. This particular patient had prescription of 39 fraction times 2 gray. Besides here, we can see a timeline with the fractionation scheme, and we can see which fractions have already been delivered in green and which fractions remain that are marked in gray. And we can, of course, also see details for each fraction. As we see here, the 5th fraction is the next, so let's go ahead and schedule it for today. And we'll push the treatment delivery machine to execute today's fraction. Now let's move over to the actual treatment. What you can see here is the patient selection screen of Cosylab treatment control system, which is in a nutshell R&V and treatment session manager for radiotherapy machines, either PT or Linac. We have here a list of the next 3 patients to be treated today in this particular room. You can also see that our patient, Mr. Johnson, is next on schedule. Now let's select Mr. Johnson and start a treatment session. This is the main screen of the session manager used to execute the workflow within a fraction. It is used for patient setup, positioning, motion control, bin delivery, and checking the overall system status through notification. It guides the user in a stepwise fashion through the entire workflow. Here in particular, we have a patient setup screen, which is typically located in the treatment room, allowing the clinical user to set up the patient on the table according to setup notes and photos. Next to it, the clinical user can also see the prescription or session notes and all of the information which can facilitate treatment execution. Now the patient has been set up, and now the session manager provides us control to move the patient to the CBCT imaging position and start the actual imaging. And now we have to properly position the patient. Let's move over to the session manager screen for patient positioning. Here we can control the image acquisition parameters, view the daily and initial images, and manipulate and verify registration of the daily image. In Mr. Johnson's case, we have a CBCT, which we will register to the simulation CT to calculate position correction, compensating for any initial setup errors. Now, I would like to stress at this point that the CBCT images are currently used only for positioning and that they're not really used afterwards. And even though they carry information about the patient anatomy and changes within. In our adaptive workflow, the CBCT images are mapped to the simulation CT with the formal image registration. Afterwards, the dose is recalculated using the treatment record, and for each fraction, finally for each fraction, the algorithm decides, based on the user-defined limits, if the plan requires adaptation or not. Niek, if you could add a few words about your experience with CBCT imaging, please.
Yeah, there's just, as Kristjan said, there's just a lot of information in those CT images that goes wasted if we don't use it to get an idea of the treatment plan. So what we're not saying here is and for the people in the proton space, we're not thinking that we're going to recalculate the dose on the CBCT, but we'll bring the axial CT into the CBCT space and allow us to then do a dose calculation just for evaluation purposes. As we said, that today the CBCT is pretty much used for setup, and we can see some anatomical changes on the CBCT, but the formal registration of the axial CT into the CBCT space can then be used for background dose evaluations and just raise some flags, as we will discuss a little bit later on.
Thanks, Niek. So before we actually do all this, we of course also have to calculate the couch correction, and let's do this now. So we'll execute the registration and accept the corrections. and move on. So for the sake of time, we'll jump the actual next few steps. But based on this correction that we calculated, the Mr. Johnson was moved to the treatment position and radiation has then started. In this demo, we are using the Cosylab dose delivery system, and on the screen we see how the radiation is monitored on the sessions manager delivery screen. And with that, all the fields have been successfully delivered, and we can close the session. Now, the session data, including the CBCT images and treatment records, are automatically reported to Oncology One, where it is used for an evaluation of anatomy and dose changes. Oncology One will now immediately start in the background to process this data and determine if this plan requires adaptation or not. Once the adaptive algorithm is finished in the background, Oncology One notifies user via email about the outcome, indicating the anatomy has changed too drastically for plan to achieve the initial prescription. So we've just gotten the email indicating a red flag for Mr. Johnson. Let's get back to Oncology One and check the welcome screen again. We can see in the schedule for the day that Mr. Johnson has a red flag. Now, at this point, we'll leave the decision up to the clinician how to proceed. If time is critical, the treatment can proceed with the current plan. However, we can also first investigate what actually happened and decide on the next action afterwards. For that, we'll open the Report tab. And we're now in the report screen where the results of our adaptive algorithm are shown. The algorithm has created a virtual CT based on the deformable image registration between simulation CT and CBCT. Afterwards, the dose was recalculated using the newly created virtual CT and the treatment records. The recalculated dose was compared to the initial dose calculated by the TPS used in the clinic and then evaluated. For evaluation, we use different parameters in the DVH spectrum or with gamma metrics. And currently, the dose is recalculated using an analytical model. In the next version, we're planning to release the Monte Carlo dose calculation. We see for this case that Mr. Johnson's bladder fill was substantially different for this fraction, which resulted in a high rectal dose. Now, I would, Niek, do you have maybe something to add here?
Yeah, I mean, I want to make clear that there's a lot of parameters one can look at. Currently, one can just visually look at the DVH curves and see where you missed the clinical goals. The whole plan lives and dies by the clinical goals and what the doctor put down and say this is what is acceptable, what is not acceptable, overdose to critical organs, underdose to tumor, or under coverage. And we'll, as this tool further develop, we can figure out by disease side what is the more critical, what is the more better parameters to look at. The fact is that we now have a tool that will calculate these parameters in the background, and the physicist and the doctor, based on the flag, can go in and look. Of course, we'll look at this in depth, but I'm really excited about this tool and happening in the background and utilizing data that would have either been lost or wasted.
Thanks, Niek. And now we've seen that the initial plan was not adequate anymore. So let's reschedule our planning tasks for the medical physicists to replan. Now, once we do this, they will see the task in their welcome screen, and we'll be able to replan the TPS, to replan the patient with the TPS that they're using. If necessary, of course, they can also schedule another imaging for Mr. Johnson. Now, please note that the red flag for Mr. Johnson will remain only until you do either a replanning or dismiss it. In either case, the clinical workflow is not interrupted, and the user has the freedom to choose how to proceed. Let's jump now a couple of weeks into the future. The plan has been successfully adapted, and Mr. Johnson has already been irradiated with the new plan for the remaining fractions. We're back to our morning routine, and we didn't have time to check emails today because there's just too much work to do. Luckily, we see that all our patients have been flagged green, including Mr. Johnson. Despite the lack of time, we still decide to check Mr. Johnson's treatment, and we see that the plan adaptation worked. The patient got the entire prescribed dose, and we can see that only the 5th fraction needed adaptation. The demonstration today used the cone beam CT images as an example, but there's no real difference if an in-room CT images were used. The adaptive algorithm we use also works for photons and particles, and the appropriate dose algorithm is selected automatically. Niek, I would invite you to say a few words about this algorithm and the overall system.
Yeah, so in the current setting today, pretty much the plan adaptation process is a total interrupter of workflow. So the patient goes back and or the therapist at the treatment console says something didn't set up correctly, right? The physicist will then have to come and reschedule physicist on a regular basis to take care of these adaptations. And so you have to go in and evaluate, you have to bring it into the planning system, the cone beam CT data, or the quality CT that was done on the axial scanner. Then some treatment planning systems allows that process, streamline that process a little bit to put the existing plan onto the new data set, and you have to calculate, then you have to manually evaluate, look at the clinical goals. It's a very tedious process. And then you have to find the doctor to say, yes, this more action needs to be required, or you can continue. Having this completely in the background, using data that's already there, not requiring some additional data or radiation administered to the patient makes a ton of sense. And then just have the flags, and then you can go in and deep dive on the flags and on the initial data displayed. And as I said, the parameters we're going to look at. So overall, this is going to be a huge improvement workflow. I talked to a Physicist colleague to me the other day and said that this is something that she was hoping some vendor or somebody will develop, and really excited about this development, ongoing development here.
Yeah, thanks, Niek. I would like to give the word now to Sašo to actually explain how our Oncology One system is being integrated into their clinic.
Thank you, Kristjan. You mentioned everything, and also Niek said that it's a waste of CBCT just for using it for a position check and not for anatomy changes. Basically, we use it to check the anatomy changes, but it's only visual, so we don't have any numerical data which we can evaluate and decide based on this evaluation. So sometimes these anatomy changes could be on a big scale, and for these cases we need to decide what is the next step for the patient. Should we treat on that day, or should we put a patient on a break for 1 day, or should we need to do a new adaptive plan? And this is a hard decision because you don't have any data which you can rely on. It's basically just a visual evaluation. And with Oncology One, we will have all this information in one place, so the decision for next step will be much easier. And currently, we are integrating Oncology One into our clinic, and we are really, really looking forward to using it on our daily basis.
Thank you, Sašo. And this concludes our presentation. I would like to thank you everyone for your attention, and I would give the stage back to Gregor. Thank you.
Thank you, Kristjan. Thank you for the presentation. Thank you, Sašo. Thank you, Niek. Let's see if we have some questions. I hope you pointed out some questions. Let me check. We have a few. Let me check. So, well, there are two questions that are quite similar regarding when this software will go clinical, and a similar one is in which markets this software is already approved for clinical use. Well, currently, we're installing Oncology One into 2 clinics with several Linux. And as you know, the workflow for photons and protons is very similar. So the real difference is only in the dose algorithm. And we're also preparing everything necessary for the certification from notified bodies. That means CE, FDA, etc. So due to our experience from other medical products that we have, we are expecting the certification to happen somewhere in the middle of next year. And in parallel, we're also integrating Oncology One with our treatment session manager called Cosylab Treatment Control System. That would be the answer. Let me check some other questions. Yeah, so one interesting question is Oncology One compatible with solutions from other vendors like Mosaic, ARIA, or RayStation? Well, each clinic, of course, has specific workflow with specific solution implemented. So Oncology One uses standard DICOM interfaces, and as long as the vendors expose the relevant data, we can, of course, integrate it. Maybe it's good to give a word to Sašo, since they are using Mosaic as well. So maybe you can comment on this one, Sašo.
Yeah, thank you, Gregor. Yeah, hello, everybody. In our clinic, we use Elekta oncology information system, so Mosaic, and integration of Oncology One from Cosylab is working really good because Oncology One is based on, as Gregor said, on DICOM protocol, standard DICOM protocol, and also on HL7 protocol. So the workflow is perfect. So it's smooth, and even if we have some trouble, because all integration have some things you need to change or to let's say to make better or so the connection work perfectly. But Cosylab have the people, so they can do this really fast. So it's, for us, it's really good.
Thank you. We have some more questions. This is a bit of technical one. What is the minimum dose distribution difference you have seen for patients during planning stage and treatment stage? Maybe Kristjan, you can take this one.
Yeah, sure. So this, we basically decided that instead of giving some hard constraints or hard limits between planning stage and then later treatment, we decided to offer several parameters to the user, and then that they can actually fine tune according to their workflow, to their limits, and to the treatment size specific, maybe what kind of limits they want to use to raise flags and then act appropriately. The algorithm itself is calculating those accurately, so you get even the slightest differences in those you'll be able to see. But of course, most of those can be just between the fine tunes or fine differences between algorithms, and they should be, so there should be some robust metric which can be, as mentioned, whatever the clinic or the user decides to.
Thank you, Kristjan. We have more questions. They are just popping up. Well, you mentioned the flags. What is the meaning of the yellow flag?
Yeah, that's an excellent question. So basically, besides from the red and green flag, which indicate plan adaptation, patients can also have, excuse me, can have some specific settings. For example, C is very relevant in current situations, so it means contagious. It means that handling of the patient should be done with care. For example, in these COVID times, if a person has COVID and still needs treatment, there'll be special equipment, special protocol, how to handle this patient. And this is then clearly seen from this welcome screen, how to handle it. You have also other flags such as pregnant or similar, and they're all used to help the user to know how to deal with the patient.
Thank you, Kristjan. Let me check if there are some more questions. Yeah, another one. So is this software an OIS or a TPS, or a mixture of the two? Kristjan?
Yeah, thanks. So this is it's a very good question. So this is an Oncology One is an OIS which has a streamlined adaptive radiotherapy workflow. So as far as we can tell, OISs usually just guide the facility and the scheduling of the patient. And we wanted to take this to the next level by incorporating automatic adaptive radiotherapy workflow. And we think this is the only kind, the only one of its kind in the world to have actually integrated an automatic adaptive workflow to be able to tell the user how to react for a certain patient without any extra effort or extra time from them.
All right, thank you, Kristjan. And we have another question. So which parameters do you think are most appropriate for measuring dose discrepancy? Maybe this would be a perfect question for Niek, I guess.
Yeah, I think so. Let me just see. This is still at least from my perspective, still a tool under development. I haven't put my hands on it. I just work with Cosylab folks on it, but I think it's very patient specific, disease site specific. You know, at certain disease sites, the doctors will look at something else. But things like gamma analysis, DBHs, all those parameters, and what I like about this tool is the configurability of it. And as this goes on, and we in the proton space, of course we're using adaptation very strongly. And there's a lot of different parameters if we look at different cases. I mean, it's just external contour changes, but primarily it comes down, as I said, to the clinical goals.
Great, thank you, Niek. Let me check if there are any more questions. No, that would be it, I guess. Kristjan, would you like to add something to the latest question?
Let me just see the poll.
No, to the one Niek answered.
Oh, no, so I think Niek explained very well. So you have different parameters, and as I mentioned before, we give it to the user. So how do they see what's appropriate, what's needed for a certain disease site or for certain even machine. We offer different parameters as of now, but I imagine this will be upgraded in the following versions. Also getting feedback from different clinics, what they found out was really relevant. And we of course intend to include all of this in our Oncology One product.
Thank you, Kristjan. So I don't think we have any more questions and we're running out of time. So at the end, I'd like to point out also that any clinic actually can be easily turned into adaptive one by starting to evaluate what improvements such a tool can bring. Thanks to everyone for participating in our webinar. And if you have any further questions, and if you would like to have a more in-depth discussion about it, just don't hesitate to visit our booth, meet us there, or contact us later. So thanks everybody to show up, and take care.